Welcome to this explainer. Okay, today we're looking into what I think is one of the most fascinating paradoxes in pharmacology. We are going to explore how we can effectively lower systemic, bloodstream cholesterol using a highly unique group of medications that essentially never even enter the bloodstream themselves. I know, it sounds impossible, right? But these drugs, which are known as bile acid sequestrants, basically act as the ultimate bouncers of the gastrointestinal tract. And their mechanism of action, it is nothing short of brilliant.
So, think about this for a second. How exactly do we manage a systemic cardiovascular issue, like high cholesterol, with a drug that sets up shop entirely within the gut? Most medications we take for systemic issues are absorbed through the stomach or intestines, they hop into the bloodstream, and travel to their target organs. But not this class. This drug class does its heavy lifting entirely locally, creating a sort of domino effect that forces your body to fix its own cholesterol problem. To really get a handle on this, we're going to use the metaphor of a nightclub bouncer.
Here's our roadmap for today's explainer. We'll be covering action and common meds, administration and contraindications, interactions and lab studies, side and adverse effects, and finally nursing care and education. Let's dive right in.
Part 1. Action and common medications.
The sequence of events here is just so cool. When the patient swallows this drug, it enters the GI tract and just stays there. It acts exactly like a bouncer. It actively looks for bile acids, which, as a reminder, are naturally produced by the liver to help us digest fats, and it binds tightly to them. It literally grabs hold of the bile and escorts it right out the back door, meaning it gets excreted in the feces. Now the liver suddenly realizes, hey, I'm missing my bile acids. So what does it do? It's forced to pull LDL cholesterol, the bad cholesterol, straight out of the systemic bloodstream to synthesize new bile. So by throwing bile out of the gut, we essentially trick the liver into burning up the exact cholesterol we want to get rid of.
And this brilliantly illustrates why these drugs are fundamentally classified as cardiac medications. The ultimate goal isn't actually to treat a stomach issue. The goal is to protect the heart and the vascular system by aggressively lowering circulating lipid levels. That decreases the overall risk of atherosclerosis, heart attacks, and strokes.
So, who are these bouncers? The three most common bile acid sequestrants you'll encounter are cholestyramine, cholestyramine, and cholecalciferol. If you're trying to remember these for an exam or in practice, do you notice a pattern there? They all start with choles or cholet. In medical terminology, chole refers directly to bile or the gallbladder. So anytime you see that prefix, your brain should immediately connect the drug to bile and, by extension, this whole unique mechanism of sweeping bile out of the GI tract.
Moving on to Section 2. Let's talk administration and contraindications.
Here is the absolute most crucial thing to remember. Our bouncer? Yeah. He doesn't discriminate. Bile acid sequestrants act like massive, non-specific sponges in the gut. Yes, for sure, they bind to bile, but if there are other medications hanging out in the GI tract at the exact same time, this drug will grab them too. It'll bind to them and throw them out in the feces before they can ever be absorbed into the bloodstream. This means it will inadvertently trap and completely neutralize other life-saving drugs if you don't time it perfectly.
To avoid that exact disaster, you absolutely have to stick to a strict timeline. If your patient has other medications to take, they must be administered at least 1 hour prior to the bile acid sequestrant. This gives those other drugs time to clear the GI club and actually get absorbed before the bouncer arrives. Now, if you miss that window, you've got to wait. You administer the sequestrant, and then you must wait a full 4 to 6 hours after giving it before it's safe to give any other medications. The bouncer has to completely leave the premises before you can let anything else in.
Now, because this medication relies 100% on a functioning GI tract and the natural flow of bile to do its job, any anatomical or physiological blockages in these systems are strict contraindications. Think about it. If a patient has a biliary obstruction, the bile isn't reaching the gut anyway, making the drug totally useless. Plus, if a patient has severe constipation or a known bowel obstruction, adding a drug that basically acts as a bulky sponge is incredibly dangerous. It'll just pile up and make the blockage so much worse.
All right, Section 3. Interactions and lab studies. Let's break down these critical interactions because they are huge. On the drug side, if you give this alongside thiazide diuretics, digoxin, warfarin, thyroid hormones, or corticosteroids without observing that strict timeline we just talked about, the sequestrant will just bind to them and render them useless. Imagine a patient not getting the effects of their digoxin or warfarin. That is a massive safety issue. Then, on the food side, because the drug binds bile, and bile is required to digest fats, the patient is going to have a significantly decreased ability to absorb fat-soluble vitamins. That includes vitamins A, D, E, and K, as well as folic acid. And you know, that vitamin K interaction directly tells us what lab studies we need to be monitoring. Because vitamin K is absolutely essential for blood clotting, decreasing its absorption means the patient is at a much higher risk for bleeding. Therefore, we have to closely monitor coagulation panels like PT and INR. And of course, to ensure the drug is actually doing its primary job and isn't harming the liver along the way, we'll routinely monitor the patient's full lipid profile and their liver function tests, specifically the AST and ALT.
Which brings us to Section 4, Side and Adverse Effects.
Since this drug basically camps out entirely in the gut, it makes complete logical sense that almost all the collateral damage is gastrointestinal in nature. The expected side effects are honestly an absolute nuisance for the patient. We're talking mild constipation, bloating, nausea, and flatulence. It's essentially just a lot of GI traffic. However, the adverse effects, the actual toxicities we have to prevent at all costs, occur when that traffic comes to a dead halt. We are talking about severe bowel obstructions, really painful fecal impaction, and severe symptomatic vitamin deficiencies resulting from long-term malabsorption.
Finally, Section 5, Nursing Care and Education. I really want you to internalize this statement. As the nurse, your role is to manage the GI collateral damage while ensuring other life-saving drugs still get absorbed. You are the orchestrator here. It is entirely up to you to make sure this medication does its job without neutralizing the patient's other required treatments or causing a nasty obstruction.
So what does this look like in practice? Physically, you've got to constantly assess bowel sounds and bowel movement patterns to ensure things are actually still moving. Now, many of these medications, like cholestyramine, come in a powder form. It is vital, absolutely vital, that you mix these powders completely with 4 to 8 ounces of liquid. This can be water, juice, or even a highly liquid soup. But hear me on this. You must never administer this powder dry. If a patient tries to swallow the dry powder, it can immediately expand in the esophagus and become a massive, life-threatening choking hazard. Additionally, as we noted with that vitamin K issue, you must actively monitor the patient for any unexplained bruising or bleeding.
When it's time to send the patient home, your education is heavily focused on combating that GI collateral damage. They must proactively increase their daily fluid intake and dietary fiber to keep the bowels moving and prevent impaction. They need a crystal clear schedule written out for them so they take this drug exactly as timed relative to their other medications. And finally, they absolutely must know to report any sudden or severe abdominal pain immediately, because this could be the warning sign of a bowel obstruction.
So we've covered the mechanics, the strict rules, and all the risks, but here is the ultimate clinical challenge for you to ponder. With a medication that requires such annoying, strict timing and one that causes expected bloating and constipation, patient compliance is notoriously difficult. So how will you build a therapeutic relationship and convince your patient to stick with the plan so they actually get those long-term cardiac benefits? It's not just about knowing the science, right? It's about making it work for the patient in the real world. Thanks for joining me on this explainer, and keep that question in mind as you head into practice.